So this is a talk I gave a few weeks back for a really cool sonographer, pair of sonographers who put together the contrast echo summit each year. And I was asked to talk about the echo contrast use in the ICU. And what you can see here on this little cartoon at the top is this is what a contrast bubble looks like under ultrasound. And the contrast bubble is made up so that we can try and enhance ultrasound reflections. And that means that we can see blood very easily, and it helps delineate it from tissue. So it's really good at something called LV opacification, which is where we look at the inside of the left ventricle. But we can also use it so that we can try and potentially, these are a little bit of off-label uses now, try and assess things like myocardial perfusion. And I'll show you some ideas about how potentially in the critically ill, we can therefore try and differentiate between someone who's got an LAD territory infarction, for example, versus a stress-induced cardiomyopathy or a Takotsubo. Another off-label use is the potential to try and differentiate a thrombus from a tumor, potentially. And that can be done by looking at blood flow within a structure. And particularly, we can look at that for RV opacifications when we get blood clots in right ventricles. And I'll try and show an example of those. So these contrast agents, what makes them so special is that they've got this gas core of a stabilized gas, which in the case of what we use most in Australasia is Definity. So it's this perfluorine carbon shell, which is like a stabilized, almost like a protein shell. An albumin shell is what they've also used, with this octafluoropropane, whatever the hell that is, this inert, stable, safe gas that's inside the bubble. So the bubble is stabilized, held together, and it means that it can reflect sound waves really, really well, because there's a really, there's lots and lots of places where you've got that air-gas interface, and that's really got, if you remember back to the physics, it's got that really high acoustic reflection gradient. So lots of sound waves gets bounced back. And so it makes the inside of the heart light up. One of the things that we have to do is we have to activate the structure first. So to make this substance work, it requires this perfluorine carbon. So if you look at the bottom left here, this is what the little vial looks like. It costs about $150 in Australia, so it's not super cheap. But you got a little, if you can see just at the bottom, is this clear structure that's maybe about 1.3 mils of clear structure, and then it's got the gas above it. So it's got that perfluorine carbon, which I think is the shell, or the albumin shell is the liquid, and then the gas is in the air. And you put it in this thing called a vial mix, and it shakes it about 3,000 times in 45 seconds, and it makes this kind of emulsion that you can see on the right there. And then you draw that up into a needle, so that makes about, I think, just under 2 mils of liquid. You then dilute that in 5% dextrose or normal saline or whatever, water for injection. And then you can either put that through a syringe pump and just roll it through at about 10 to 15 mils an hour, or you can run it through a little bit faster if you want, or you can put it in, as what I mainly do is I just bolus it 1 or 2 mils at a time.
Sorry, Sam. So you'll dilute that out and say 10 mil syringes.
20 mil syringes. 20 mil syringes. So you draw that 2 mils of activated Definity into a 20 mil syringe.
Yeah. And they just put a little squirt in.
And then a little squirt at a time. And it's meant to be 1 vial per patient is how it is sold. I'll be honest, at $150, I don't do 1 vial per patient. Sorry, Definity company. We tend to, if we've got a group of people, like when we do our contrast clinics, we will use 1 vial between 2 to 4 patients sometimes to try and save money, because this is not reimbursable on the Medicare rebates at the moment particularly for inpatients.
And can you wash out your images if you use too much contrast?
Absolutely, and I'll show some examples of that in just a second. So this is what we'll first start talking about. So this is what Definity is licensed for, which is called LV opacification. So the theory is that you've then got this relatively stable bubble. And this bubble is small, right? I don't know if you saw it on that first cartoon. It's less than 10 micrometers in size. And that means that it's small enough to fit through capillaries. So you can inject it into your vein. it will then go into your right atrium, right ventricle, and up into your pulmonary circulation. And it's small enough to go through the pulmonary capillaries, which means it then enters into the systemic circulation. And it lights up the inside of the heart like this, which makes it very, very easy to see that endocardial border definition, which means it's really good for doing things like ejection fraction, regional wall motion abnormality. And I'm going to show you examples of how it's absolutely essential to try and pick up cardiac function and thrombus. So the kicker is that you can't use normal mechanical index. So that's the power of the ultrasound wave. You've got to turn it down to about 10% of what it normally is. So we're normally working at mechanical index of about 1 or greater when we're doing standard transthoracic imaging. You've got to press the setting that takes you down to 10% of that so that you don't destroy the bubbles. So if you do inject too much, this brings up to Ben's question about how, you can either just wait, because the bubbles only spend about 3 to 5 minutes in your circulation before they're destroyed. And they're destroyed just by the bubble bursting as they go through, particularly the pulmonary capillaries. You've got maybe a couple of mils of air that make up the bubbles, so that could easily get just washed out and blown out in your lungs. So it is a safe thing to use. And particularly for the ICU, why I think this is important in the intensive care unit, and we're still not using it enough, and I think we could use it more, is that we know that up to 30% of segments in ICU patients can be uninterpretable. And this isn't a relatively small study, and I really think we should actually have a look at this to see how many patients. Well, we do a lot of echoes here. We'd be doing, maybe 700 a year in our ICU patients, and we've only got 21 beds. And I wonder how many segments we can't see when we're analyzing these patients. So this study suggested that, up to 10 to 25% of the patients, you couldn't do reliable ejection fractions. You could potentially have an argument about how important ejection fractions are, but I think for regional wall motion abnormality, it is important to know if you've got regional wall abnormalities. So I'll show you an example. So this is case number 1. We use contrast when you need to get better views. So in this 70-year-old man who was intubated for a drop in his GCS, CT brain was done urgently, which was suggestive of a basilar artery stroke. This gentleman was known to have ischemic heart disease, a bad heart. So clearly we need to know if there is an embolic cause to it. And these are the pictures that we get. So I might just let you have a chance to have a look at it and tell me whether you think that there is. So first of all, we know he's got bad ejection fraction. He's got a raised left atrial pressure. He's clearly got some regional wall motion abnormalities. I think that septum and that apex are akinetic. But what do you think about the confidence you'd have in suggesting that there was an embolic cause of thrombus there? Anyone confident to make a call? Online or otherwise?
I wouldn't exclude thrombus, no, but just no way.
Exactly. You can't exclude it. Yes, sorry, was it someone online?
Look, I wouldn't be super confident, but I'm very suspicious.
Yeah, great answer. And I think that's right. And I think that's exactly how I would put something in my conclusion, saying that although it's impossible to say definitively, there is a suggestion that there may be a thrombus, but you need to do a contrast study. And what's so interesting is, as we do this contrast study, and I'll just run it through in a second, is how much more confidence you can provide to that answer. So Drew, I'm going to see how confident you are in a second. First of all, as I let this run, I just want to show you the contrast. It comes into the right atrium first, then moves into the right ventricle. And it should be in about 4 to 5 cardiac cycles before it enters into the left ventricle. And what we can see quite clearly is with this patient, it took a lot longer. And that's because it is output dependent, right? As you move from one side to the other, if you've got a higher cardiac output, it comes faster. As with this one, it moves slower. I'll now just play a few images. So first thing we can have a look at is that endocardial border definition is so much greater that you can start making more accurate estimations of ejection fraction. You can clearly see where the endocardial border is. That might be useful in patients where you've got things like chemotherapy-induced cardiotoxicity or something like that, where ejection fraction is very important, but also for regional wall motion abnormalities. If you change your gain settings around a little bit, you can start to get a little bit more clarity and a little bit more off-axis imaging. And Drew, how are you feeling now about trying to diagnose whether there may be an embolic cause from the heart in this one?
I'm very confident now.
Yeah, very good. Excellent. Me too. And you get this idea, and this would, for me, would be an example of someone who's got a chronic thrombus. It's got quite a laminar appearance. It's got quite well defined sharp edges. You wonder if a part of it's been broken off, and that's what caused the basilar artery stroke. It looks sort of very, very dark. There's no, I'll show you an acute thrombus in a minute, and you'll see that that's got much more of a sort of a more gray appearance to it, even under the ultrasound. This one is just utterly black and dense, and the ultrasound waves are going nowhere near through it. So this is someone who's got a nasty chronic thrombus. Yeah.
Just with the focal points there. So what's
Very
the
nice.
right position? Some people keep it away so that it does not destroy the bubbles.
Yeah,
Some people keep it.
yeah, what a great question. I mean, I think probably it's probably splitting hairs when you're imaging at 0.1 of a mechanical index. It probably doesn't matter too much. I think that's been left over from when we were imaging the apex when we were in 2D. So it shouldn't matter too much, I think, when you're doing low mechanical index.
So I think what's beautiful about these two clips you're showing is on that standard apical 4, you can't see it, even with the contrast that you can't see it.
Absolutely.
You have to go off axis.
And how much bigger it is. I mean, if I had to guess on that first one that Drew was talking about, you know, I'd have thought it was small, and this one was just like, holy Christ, yeah, this is off the charts, right? So is it safe? You know, this I think is probably the big question that was about maybe 10 years ago now. So contrast's been around since, I think it's almost around since the 1990s, could be even earlier. And it was originally came out with a big black box warning that you couldn't use it in patients that had pulmonary hypertension, who had holes in their heart, which is probably potentially still true, and if patients were cardiovascularly unstable. I think we've got pretty good evidence now to talk about the safety profile. And I think as these agents are better developed now, that the safety profile is actually, it is a very, very safe thing to use, both as outpatients for stress imaging and also in critical care patients. In these enormous studies that have been done, you know, this is on like 6,000 echoes. This study was done by David Platts, who's up in Brizzy in Australia, who does a lot of contrast use, and he's absolutely amazing in some of the research he's done, and I really commend him for that. But they found that it was remarkably safe. You do get anaphylactoid type reactions. So that means that patients that may have a bit of a dip in their blood pressure, a bit of an increase in their heart rate, bit of lower back discomfort, maybe some shortness of breath, but it is very transient, goes away after 2 to 3 minutes after you stop administering the medication, and severe reactions are incredibly rare. We've used a lot of contrast in our time through the ICU and in our echo lab. The only serious event that I can remember was in a lady who was 86 years old, who was the mother of a very eminent cardiologist from one of the big centers in Australia. And she had asked Faraz Pathan, you know, the co-head of the echo lab, to do this, especially because Faraz is such a brilliant sort of sonographer and cardiologist. And it just happened to be at that one that Faraz caused this quite serious hypotensive episode, which was very short-lived, but he did have to give some adrenaline. We did bring this lady urgently down to the intensive care unit. She was totally fine, but inevitably in the one patient, from a professional perspective and your own ego, you didn't want to have an allergic reaction. It did have to be the mother of your, you know, the cardiologist or something who taught Faraz. But anyway, it still makes me laugh every time. The lady was fine. I do apologize not to make flippant remarks about it, but it made me laugh for Faraz's benefit anyway.
Extravasation.
No problem with extravasation. I think it was just a minor hypotensive episode, but in a lady who was a bit frail, that had a, you know, she felt unwell. It freaked the hell out of Faraz. Met calls were called, urgent admissions to ICU. We didn't actually have to do too much, but so I don't know whether we can put that in the rare in the benign category, but maybe. We got some pretty good evidence. This is one of my favorite bits of literature in the whole world. It's a good study in terms of it looked at an awful lot of patients who had contrast versus those who didn't, and they were particularly in inpatients, and there was a significant majority of these patients who were critically ill. And they just did a simple statistical analysis where they took these inpatients, and I said there's a significant portion of critically ill, and they had over So I think they looked at over 1 million TTE in inpatients, and they had 16,000 of them had contrast, and they just compared their in-hospital mortality, and they found out that you were less likely to die if you had contrast administered to you. I'm not quite sure that's okay from a scientific point of view in terms of hypothesis generating, because I don't know, there are potential ways that this sonothrombolysis maybe, but I think this would be using a p-value when it's not entirely where a p-value should be used of less than 0.5, proving your point. But I think what it does show, which I like about it, is it does show that contrast use is safe. It's certainly not causing any harm in patients, and that's really exciting to see, and that's useful to see in inpatients, a significant portion of whom were critically ill.
Maybe just using the term ultrasound enhancing agents instead of contrast will lay away.
Oh, man.
It's Michael. Can I ask?
Hi, Michael.
The issues about pulmonary hypertension that was initially on that black box warning.
Yeah.
Do you know if anyone's ever given this contrast with PA catheters in or during right heart caths, and does it change anything?
I'm sorry, I don't know whether they've done it with right heart caths. It's certainly been shown to be safe in that population as well. And there are also studies showing it's safe in patients with congenital heart disease. So all of the areas that have been given black box warnings, that black box warning has been reduced. They still say you've got to do it with cardiopulmonary monitoring for at least 20 to 30 minutes for everyone, and just have an idea that you have medications available to deal with anaphylactoid type reactions. That's what the guidelines suggest. I don't know of any studies where they've actually done it with a PA catheter in.
Okay, thank you. Awesome.
Cool. All right, let's go off label now for a little bit. I'll just do a shout out to some of the live scanning that we've been doing on the website. I don't know if you guys have seen it. So there's just a QR code link here to a case that we did with first of all, discussed it with Santosh, one of the cardiologists, and then Faraz, we did a study together. And particularly, we were doing it for LV opacification, but also to try and assess myocardial blood flow. So let's take an example of a 66-year-old guy who comes in with chest pain. He's got a STEMI. He's a smoker, family history for ischemic heart disease, and he goes to the cath lab, and he comes to the ICU afterwards for dobutamine. And they found an LAD, 100% LAD territory infarction. And the whole case, you can see us go through the echoes and the angio with Santosh, and then there's the live scanning of when we were doing the contrast. So if you want to have a look at that, there's the QR code, and it's on the website. So this is the angio. I don't know if you can see just where that bifurcation is happening, but there's just a little nubbin that comes off in the middle of it. I don't know whether I can show it if you can see my mouse, but there's a little nubbin that comes off just in between where that bifurcation is, just off the left main, which is where you've got 100% of the left anterior descending artery, which is occluded. And as they start to put wires across it, you can start to get an idea of the sluggish, terrible blood flow that they had through that blood vessel that's coming off just a little nubbin at the top there, and how they start to put wires down to try and open it up. And they do a balloon angioplasty through that 100% stenosis and put a stent through it. And hopefully you can get an idea of the improved blood flow that they started to achieve through that LAD that you can now see starting to open up at the top. And you can sort of see there are 3 blood vessels rather than the 2 that there were before. So this is a clear example of someone with a STEMI, right? And so we were looking at the echo afterwards. Just in the meaning of time, I might just sort of flick through some of these things, but you get the idea that we can see the regional, so we can see the walls, and they're okay to see. I think we can get an idea that there's some anterior akinesis. That's what wall are we looking at here on the parasternal long axis view for the septum?
That's anteroseptum.
Very good. And we're looking at the infralateral wall there. So that anterolateral septum, I think you get an idea that the anterior wall also looks akinetic in there. But then interestingly, when I was reporting the echo, we saw this on the echo, and you're like, huh, that's you got that eyebrow moment. I always think of sonographers when I see something like this, because I'm sort of, if I'm drinking a cup of tea, I love to drink tea when I'm doing it. If I've accidentally spat out some of the tea as you see this kind of image, I think of the sonographer, and they're often really good at their poker face. Imagine coming across this, and what you can't go is like, oh, holy gee, oh, what's that? That's, oh my God. You can't do that as a sonographer. You got to have your poker face on. because you got this smoke, you see this like, you know, this wispy stuff that comes through, clearly a horribly akinetic apex, and that apex looks really weird. You know, that is definitely suggesting that there is a thrombus in there. We've got that spontaneous echo contrast. Everything is ticking the box to suggest that you've got a rip-roaring thrombus sitting up there. But are you sure you're not dealing with apical non-hokum or a non-compaction kind of thing or something else? You know, I think there's a lot leaning towards here to a thrombus, but I think it's a great example of when echo can be really useful to give you ejection fraction, regional wall motion abnormality. And let's have a look at this thrombus. This is what I wanted to show this because this is what Faraz calls poor man's contrast. I'm not sure about really. So poor man's contrast, where you use color Doppler, reduce your scale, get your focal position up where you're interested in, you know, near the apex, and you try and see if there is a bleed of Doppler over the structure. You know, are you looking at a real structure? Is it an artifact? I think you get an idea when you've got the flows low that you've got low flow in the apical areas. I think you can get a suggestion that probably I don't think there's bleeding over there. It's just a bit of a color Doppler artifact. But I think the contrast is the best way of doing it. And this is a great example of someone with an acute thrombus in there. First of all, you get that suggestion there in the apex of that sluggish blood flow around the apical region. And then if you're looking carefully, you get this almost heterogeneous sort of appearance under the ultrasound when you got the contrast in there of the acute thrombus. So it's not quite as dark as it was on that chronic thrombus we saw in case 1. And this has more of a heterogeneous appearance under contrast. And this is an example of an acute thrombus. So what we did next with this guy is to try and make an assessment of how his blood flow is. You know, when they do angios and they're opening up these areas, the way that some of the cardiologists and Santosh describes it to me is he says that we often trash the microcirculation. And what he means by that is as you put in a balloon and you inflate up a blood clot, you can break up part of that clot and it goes downstream. And it breaks up into smaller bundles. Some of it gets trapped by the scaffolding of the stent, but you do send a whole bunch of blood clots distally. And that means that you can destroy some of the microcirculation, right? Now, with the contrast, we know that I told you before that it goes through the microcirculation of the pulmonary circulation. That means it also goes through the microcirculation in your systemic circulation. And that includes the microcirculation in the myocardium. And so what we can do with echo contrast is, if I sort of try and explain it like this Mayo cartoon shows, is that if you've got the contrast inside the heart, if you can provide a burst of higher intensity ultrasound, which is, you know, sort of at normal ultrasound levels for half the cardiac cycle, it destroys the bubbles in the area of that ultrasound where you're sending the ultrasound waves through. And then you can watch as those bubbles then come back into the myocardium in particular. And that can give you an idea that if the bubbles come back quickly, that's normal. If they come back really sluggishly, that means that you might have some form of stenosis. And if it doesn't come back at all, that can give you an idea that you've got some area of infarction. And we'll show you what it looks like with Faraz here. And I'll let Faraz just wax lyrical about this because he does it much better than me.
And you're coming through. Here we go. Now you can clearly see the bubbles within the myocardium.
Yeah.
What you see is that there's a paucity of bubbles around this region.
Yeah, absolutely.
And that is the area of microvascular obstruction. This is a thrombus, but because the sequence is optimized for myocardium, we're not getting as clear images of the cavity itself. So if you eye scan it here.
So just to summarize, so you're saying that if there's lack of those contrast bubbles, those small bubbles which are smaller than the red blood cells, we haven't got those in the apical papillary network,
just
and that's
here.
Because of the
Microvascular.
the recent LAD territory infarct.
And here we can flash, and you see the bubbles will fill in these regions.
And the normal time frame, like 5 to 7.
Whereas they don't fill in.
I find out I sound smarter if I repeat everything that Faraz says in a slightly different way. That works well. But no, I think Faraz says it best. So that's a way that we can do myocardial contrast imaging in standard cardiology patients. I'm now going to take it to the ICU group now, okay? So let's say we got a 68-year-old woman, she's in respiratory failure and she's intubated and transferred down to us from another hospital. She had a pneumothorax secondary to this ruptured emphysematous bullae, we thought, and she was and got a history of cancer in the past before and had a Hartmann's. So she comes down with significant ECG changes, troponins well over 3,000, and this diagnosis of a potential non-STEMI secondary to this insult that she'd faced. And when we look at these echo images, it's a pretty significant regional wall motion abnormality, right? We've got the entire mid and apical level, which is akinetic, and the basal levels that have relative hyperkinesia. And you'd be thinking, of course, with this, well, diagnosis of exclusion, but you've got a lady who's postmenopausal, who's had a significant insult, who's got significant regional wall motion abnormalities, who's got troponin elevations, and the echo features that might fit with a diagnosis of a stress-induced cardiomyopathy. Now, these patients, I'm not for 1 minute suggesting that contrast and looking at the microcirculation is going to be able to prevent this patient from needing to go to angio. But if you think that someone's got a significant LAD territory infarct like this and that they're sick, these are people that you may need to expedite and send to angio sooner rather than later. And if you've got something like, let's say, acute kidney injury going on with this, and they're, on the border of needing dialysis or something, I think that plays into your anxiety levels about sending a patient for angio, for example. And so potentially having a philosophy of trying to use contrast to assess their microcirculation, it's not perfect, but it can give you an idea of which way you're facing. And maybe that might help sometimes with patient decision-making. I also think it's really cool and makes nice pictures, and it's really amazing science and a good way of using echo. And it is safe, but it's not, you do have to worry about causing hypotension and anaphylactoid type reactions. But as I said, I think it's relatively safe. It's non-invasive. I think it is. I've found it useful at times. It's not all the time, but I have found it useful at times. The other patient group that it may be useful in is in patients who are brain dead, and trying to figure out if someone who's got an ejection fraction of 40%, if you can show that they've got normal microcirculation perfusion, potentially that might be an indication where in future we should say maybe we should potentially not discount these patients from being cardiac donors, maybe. Anyway, I'll show you what it looks like. This is this lady. So this is what her heart looked like, burst of high intensity ultrasound, and really clearly you can see little bubbles appear in the part that's akinetic. I'll let it run again and just watch little bubbles, just they're right there, and they come back in within 5 cardiac cycles. And I felt with a pretty, you're like, man, there's bubbles in there, right? It's not perfect, I don't know, but I think that shows that you've got normal coronary arteries, and this lady looks like she's got a stress-induced cardiomyopathy, and sure enough, she did. That's a subjective estimation. You can also, you look at it in obviously lots of different angles. Have another look on this one, burst of high intensity ultrasound. And little bubbles coming back into the microcirculation of the apex. You can do it quantitatively, which is a massive pain in the arse. You put a little region of interest over a segment, and then you try and look at how the acoustic intensity increases over time. And obviously you're starting off at a baseline of 0, and you hope to get back up to a steady state, which happens in about 4 to 5 cardiac cycles. And that's normal. And so that's what normal looks like. And you can have patients where it doesn't rise up at all, and that's someone who's got impaired circulation. It's not perfect. We did a study on it, did this as part of my PhD. And what we found is that what I enjoyed a lot about this is I took this to, I'll try and remember now, I think I took it to 8 intensive care specialists and 8 cardiology specialists.
No respiratory, that's your problem.
And I gave them clinical information, ECG, echoes, and troponins. And I said, do these patients have ischemia or not? And see, because we all think that we can pick a Takotsubo, right? And what we found, and then I compared that to a reference standard after this, which was MRI, angio, I think one patient had a sort of nuke med. That's not a great way of doing it. And a lot of patients, actually a significant portion, didn't get angios at all, but just had complete recovery of their cardiac function. So again, the study's not perfect. But what was great is that with clinical acumen alone, we didn't have a significant way of figuring out whether it was ischemic or not, which I thought was quite interesting. But you add in the myocardial contrast perfusion analysis, and it started to help. And you were able in a significant manner to pick up ischemia or not. That was done with subjective analysis, was pretty good. And you do it with quantitative analysis, it was maybe a little bit better. But again, just a proof of concept that maybe it could be useful in the critical care context. I'll finish up now if I've got 10 minutes left just to talk about RV masses. So this fourth case is a really interesting lady who was in her 60s. I'm sorry, I've forgotten the history, forgot to put the history down, but she was in her 60s here a few months back, and she had a very nasty PE, which she had a brief episode of hemodynamic instability, and that then recovered with some therapy, and she was going to be started on heparin, but another clot was found, and she had a precipitous drop in her platelets, and she was found to have heparin-induced thrombocytopenia, so was put on donapamide after that. But so clots were forming on top of clots, unfortunately, and we had an echo that was done when she had a second episode of hemodynamic instability, and there was a lot of nervousness about giving thrombolysis. And this is the echo findings that show, obviously, we've got a terribly dilated and severely abnormal left ventricle function. It's likely been around for some time. She's got a massively dilated left atrium as well. The right ventricle is not happy, and she's got what looks like a very nasty echogenic lesion. There's likely a thrombus sitting there in the right atrium. There was also a concern that there might be something sitting there in the left atrium. Oh, sorry, in the left ventricle. So this lady moved on to have contrast. And if you remember that we normally look at the right side of the heart, it can be quite hard to look at with contrast because all the contrast goes over to the LV, and that makes it sometimes harder to see the right ventricle. So I think a sonographer did a wonderful job trying to analyze the mass in the right atrium very quickly. And what you can see is that there's a relatively homogeneous black density to this thrombus. So there's a lack of blood supply within that thrombus, and that may suggest that there is no blood flow within it, which obviously fits with thrombus. I think that's not perfect. Again, we saw that acute thrombus in that case before. It can sometimes be hard to differentiate hyperacute thrombus probably from a mass that's got blood vessels within it. But I think on this case, we're able to look at it and say, well, yeah, that's not a tumor that we're seeing. That's a thrombus that she's got in there. And this lady's got thrombus on top of thrombus. So whatever you do, don't stop the anticoagulation that's not heparin. What was interesting though about this is that we found more clots, and what we'd missed on some of the first imaging was the clot that was the massive apical right ventricle thrombus that was flicking around in her heart as well. So this lady had multiple thrombus that was sitting in the right ventricle. In terms of the left ventricle, we were able to look at that and come to the conclusion we thought that was a papillary muscle rather than a nasty mass. But again, it was a really nice, elegant demonstration, I think, of using contrast to look at not just LV opacification, but RV opacification and RA opacification. It just takes a little bit more nuanced imaging, but really nice images. The last one here is the final one that was done several years back now of a gentleman with an RV mass. So he was a post-op patient for head and neck cancer. He had shortness of breath to look for a CTPA, which was, thank goodness, negative for PE, but it did find a suggestion that there may have been a mass in the right ventricle. And this incidental finding of this right ventricle mass sitting at the top of the RV led to us to want to go and do an echo. And the echo was really hard. And it was a bit hard to know whether we were looking at a very prominent moderator band, or whether we were looking at something else that may have been related to potentially previous cancer diagnoses. And I think the imaging is it's not challenging for this guy, but you can see how hard it is to try and differentiate a apical RV mass with that. And that's where contrast can really help. And what helped to see us with this mass is that, first of all, I think we can see that it is potentially maybe close to the moderator band, but it does look like a definitive structure all unto itself that is moving with the heart wall. And this mass has its own blood supply, which if you see as the burst of ultrasound comes in, you can then see that there are clearly little bubbles that sort of flick through that mass as the cine plays. And I'll just leave it going so you can get an idea of that, which helps try and tell us that this is therefore unlikely to be the moderator band. It could easily be something that is related to previous diagnosis of cancer, and this therefore suggested that we should be looking for a biopsy of this and trying to find out what was going on. And thank goodness it was found to be related maybe to the previous head and neck cancer mass. It was very slow growing. They've not done anything and just kept an eye on it from there. But it was, I think it was a very useful incidental finding from the CT, and echo helps try and guide that. And it was just a way of trying to differentiate tumor from thrombus. Okay, last couple of things, something a little different. So as well as sort of in this research space for off-label uses, there are studies coming around, such as this one, which is a great study from, I want to say, the Netherlands. I think I got that right. It could be Germany, where they look at it for ECMO. And I don't do a lot of ECMO, but I know that when you're doing VA ECMO, there's sometimes concern about where the watershed area is, which is where the atrial, where the, and help me out, Michael, if I say this wrong, but it's where the sort of ECMO oxygenated blood flow, which is coming up into the aorta and it's going the wrong way, meets the native blood flow that's coming out. And you need to make sure that that's both not too high or too low. And you're looking for potentially having an idea where this watershed area is, which is where the artificial flow meets the native flow, can be useful. And you want to have it approximately in the mid aorta. And these guys you'd contrast to try and find that. So using abdominal imaging, they turn off the bubble alarm on the ECMO circuit, inject contrast into the ECMO circuit, and then look as it goes up into the circulation. And can find quite elegantly in over half of the patients, it wasn't perfect in all of them, but they found where that watershed area is in a safe manner, and there were no problems with that. And I thought that was quite a nice, elegant extra use of contrast. So I guess in conclusion, contrast use is safe in the critically ill in the vast majority. You do need to be able to monitor them. You do need to be prepared for anaphylactoid type reactions. If you do see anything, stop giving the medication. Symptoms seem to settle down in a matter of minutes. It's really easy to perform if you haven't done it. I'd love to show you. It's not rocket science by any stretch. Just got to turn down the mechanical index. There are presets on the machines to use if you can. Which seem to work well, but otherwise you can do it manually. Off-label uses may be useful. There's some nice research, I think, to look into, particularly for perfusion studies of the myocardium, and future developments. They are happening all the time. So thank you very much for listening to that. Are there any questions?
I have a question, Sam. Thanks for the presentation. I want to know how we can get funding so that we can get that as well.
I agree. I think we need to. I think it's difficult. I think funding for echo stuff is getting less and less these days, it seems, through Medicare. It is funded for, I think it's outpatients only, but it is not funded for inpatients. And I think lobbying is the best way that we can go through this. You know, I think particularly in the critically ill, wouldn't it be wonderful if we could have an echo contrast study for the critically ill? And I think there are significant, we could provide significant evidence to show that it is useful. But I think evidence is needed. Evidence in the critically ill is not out there at the moment. And you're more than welcome to start trying to help us. And maybe this is where larger studies, where we look at showing how many times we can't figure out regional wall motion abnormalities or ejection fraction accurately in critically ill, when you've got decent people doing it, that's be a great place to start, I think.
Yeah, cool. Second question is not the case that you and I did, but the one after that. It's a question about 2D, where thrombus looks like on just plain 2D. I noticed that it had kind of a hyperechoic rim to it. And somewhere in my mind, I've been told that that's more of an indication of chronicity.
Yeah.
But when you use the contrast, it was kind of in the case, it was more of a kind of an acute apical thrombus. So my question is that perhaps that's the answer, that it's not a reliable sign? If you see
Yeah,
an
absolutely. I mean,
echogenic-
I think all those 2D features of thrombus are subjective at best. It's probably a bit like an RV free wall estimate. I think the classic teaching that I've heard is that on 2D imaging alone, not with contrast, so just 2D imaging alone, acute thrombus can have independent motion. It's generally a homogeneous type appearance of a light gray. It is echogenic, but it's a light gray, homogeneous, smooth surfaced in areas of low flow. As it becomes more chronic, it becomes more layered, so you can get different bands in it, or it can be more heterogeneous, and it can become more bright as it's almost more sort of scarred, if you like, or it forms more of a dense thrombus. It can be more echogenic, and it can be a bit more craggy or more laminar. So if you've got the apex of the heart, it can be sort of more what do you call it? It's got more acute angles at the edge, as opposed to an acute thrombus. It's got more just of a kind of a lumpy appearance, like that one in the right atrium of the last patient. So for my classic things, if I look at that thrombus in that right atrial case of that lady with the hits, that's an acute thrombus, homogeneous, independent motion, bouncing around a little bit, smooth-walled, homogeneous, light gray. Chronic thrombus was that first case that you had a look at, where it's kind of got that area to it. It's kind of got an echoic edge, and it ain't perfect. Maybe a better example, it's a bit like regional wall, trying to tell the difference between an acute or a chronic regional wall, and a chronic regional wall motion abnormality. It's thinned, it's bright, it's akinetic, as opposed to a acute regional wall motion abnormality that's normal thickness, echogenic, and it can be hypokinetic or akinetic.
Thanks, Matt.
Pleasure. Any other questions? Thank you all very, very much for listening. Guys who are doing the DDU, don't forget to check out Chris's vascular talk. That might be worthy of looking at, particularly. There will be a question on general ultrasound in the written and in the Viva. Okay. Cool. Thanks, guys. Best of luck.
Thank you.
Thanks, Em.
Thanks.
Hello, everyone. My name's Shagan Olusanya, and I'm a consultant in intensive care medicine and ECMO at St Bartholomew's Hospital in London. On behalf of the BART and the Nepean Critical Care Echo faculty, it's an absolute pleasure to invite you to our second Advanced Critical Care Echo course at St Bartholomew's Hospital in London on the 19th to the 21st of July 2024. Our ethos is simple. We are a group of people who are passionate about critical care echocardiography, who are trained and accredited in advanced techniques. We actively practice these skills and have seen the difference that echo and ultrasound at a high level can make to patient care. Whether that's the rapid differentiation of shock states, identifying left ventricular outflow tract obstruction, or even measuring ventricular arterial coupling, the probe that you hold in your hands is capable of far more than you think, and we would like to teach you those skills. Who is our course for? Well, it's an advanced course, so we'd expect you to have some basic ultrasound and echo skills under your belt. It's ideal for people who are studying advanced accreditation, such as British Society of Echocardiography or EACVI Level 2, the European Diploma of Echocardiography or EDEC, the American NBE in Critical Care Echo, or the Australian Diploma in Diagnostic Ultrasound. We'd also recommend it if you deal with complex patients such as those on ECMO. Our course will feature live scanning on models, transesophageal echocardiography on our HeartWork simulators, and of course the ever-popular dissection section led by Associate Professor Sam Orde from Sydney. We'll also be showing you 4D echo and strain imaging with wonderful machines thanks to our sponsors at GE Healthcare. See you all soon.